Hi, this is Brian Kim. I'm going to share with you this case of a patient with a dense Morgagnian cataract. I'm going to show you how I disassembled this lens. This patient's also mentally challenged. He has Down syndrome. It was very difficult to examine at the slit lamp, and it was actually even hard to determine if he had a sublux lens versus a Morgagnian. So this patient was referred to me because of the challenging situation here. So once the patient received a retrobulbar block and received the propofol drip, I was able to go ahead and see him under the microscope for the first time. And you can see here clearly this patient has a Morgagnian cataract. This is a right eye. You can see the lens has drifted down towards the right with gravity. And so it's difficult to appreciate. This is a pretty dense lens, but thankfully he's pretty cooperative right now. So I'm using a cotton tip to hold the eye and use a corneal marker to help me center and size the rhexis. I'm going to use my paracentesis blade to make an incision first on the right side and then the left side, and I'm going to make sure I make the blade parallel to the iris plane to get a nice corneal shelf, which will allow me to achieve a self-sealing corneal incision. I'm going to inject some intracameral lidocaine and then some intracameral air in preparation for trypan blue. I like to drip the trypan blue and do a paint roller effect. I don't like to inject the trypan too vigorously because I don't want it to go behind the anterior chamber. I'm injecting some dispersive viscoelastic in such a way that it pushes out the dye and the bubble, and I'm using the cannula to hold the eye so I can do my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then enter. And I'm using the cannula to control the eye as I do this. Because this is an unusual case, I decided to use the systotome to start the rhexis. I puncture and I pull towards the left, and I start to create a little bit of a flap. And you can see I'm going to create the rhexis about 1/4 with the systotome. Once that's done, I'm going to use my rhexis forceps to complete the rhexis. Again, with a Morgagnian cataract, it's very difficult to sculpt. It's very difficult to control the lens, and there is absolutely no support. There's no cortex. There's no epinucleus to buffer you during the disassembly of the lens. And so the posterior capsule is right in your face. And so you have to do some other techniques, and I do feel like mechanical fracturing techniques works quite well in these situations, in contrast to other cases where you have to sculpt or you have to lollipop the lens. You do need to have much more control of the lens in those situations, and you just don't have that when you have a free-floating lens. So I go ahead and finish off the rhexis here. So I switched to hydrodissection, but again, if this is a truly Morgagnian cataract, there's really nothing to hydrodissect here. And so lo and behold, you can see as I'm manipulating the lens with the cannula, it's just kind of moving around. And so there's no reason to hydrodissect, but it was nice to at least confirm that the lens is free floating in the bag. So I inject some dispersive viscoelastic underneath the lens to push the posterior capsule backward. And I want to create a viscoelastic barrier so that when I do the phaco, I'm not going to be near the posterior capsule. So I go ahead and try to initiate my standard technique, which is my double chop. I place the chopper around the lens piece, trying to get around the contralateral equator. But as I do this, the lens starts to slide around. So again, you want to imagine this lens is this slick, slippery, free-floating lens within a large capsular bag, and that did not work. And so I'm using the chopper to help manipulate the lens in such a way that I can get it around the lens piece. And in doing so, I actually turned the lens vertically, which was fine. So now I'm able to, I can place the instruments on each side of the lens, sandwich it and crush it. And so now I have like a Pac-Man lens. I've cracked the lens piece, but it's like a Pac-Man. It's not completely separated. And so now I'm going to try to go around the lens piece again and try to chop it and crush it. But as I do it, it's a little bit awkward. I'm using a little bit of vacuum to hold the lens piece first, try to turn it a little bit, And then I'm going to try to sandwich the lens piece between the chopper and the phaco tip. But you can see that was really not very successful. So I decided to switch gears. I take my instruments out, I inject some viscoelastic in front of the lens as well as under the lens, and I'm turning it. And so I'm going to try to actually deliver the lens out of the bag. And so I'm using a reverse Sinskey hook to go under the lens and go around the contralateral equator and just pull it up out of the bag. And so it comes out really, really nicely. And so I go ahead and inject some dispersive viscoelastic to coat the corneal endothelium and push the lens back. And so I go back and see if I can further divide the lens with my technique here. So here I'm going to try to go around the lens piece completely. And then you see it turns tilted and vertically, and then I crush it. And it actually creates one quadrant that's now separated. And so I'm able to crush that one quadrant, sandwich it with mechanical fracturing forces, and then start to emulsify the lens pieces. And this is a very important point. I use a little bit of vacuum to position the lens piece on my tip, but then I turn the vacuum off when I actually crush it with the chopper and the phaco tip. And so that's very important. When I use a vacuum to hold the lens piece on my tip, I'm positioning the chopper deep in the bag to protect the posterior capsule. But then when I'm actually ready to crush the lens between the chopper and the phaco tip, I turn the vacuum off. And that is the point of mechanical fracturing. You don't want to use any fluidics during the fracturing moment. Of course, I have to position the lens in front of me, and so I use a little bit of vacuum to do that. But during the actual fracturing moment, no vacuum or ultrasonic energy is used. And that is why this is such a safe technique, because when I'm doing the chopping maneuver, I am not going to be initiating any vacuum. Therefore, the posterior capsule is not going to be vulnerable to being grabbed with the phaco tip. So again, when I'm positioning the lens piece on the tip with vacuum, I'm placing the chopper deep in the bag to protect the posterior capsule. Once I have the lens piece, then I turn the vacuum off, and then I sandwich and crush the lens piece between the chopper and phaco tip. Once I'm ready to emulsify the lens pieces, I keep the chopper deep in the bag and I start to emulsify the lens pieces. So this is the last quadrant. You can see I place the chopper around the lens piece, pull it centrally, crushing it against the phaco tip. Again, I'm doing this without actually any vacuum or ultrasonic energy. And then if I can position the lens piece without vacuum, I go ahead and don't use vacuum, but just mechanically manipulate the pieces between the chopper and the phaco tip, crushing the lens piece. But sometimes if the lens piece doesn't come to, I do a little bit of vacuum to get the lens piece on the tip, and then I crush the lens piece between the chopper and the phaco tip. But again, when I crush the lens between the chopper and the phaco tip, I am not initiating any vacuum. And this is why this is a very safe technique. And again, very safe as far as protecting the posterior capsule. The posterior capsule is not going to be vulnerable whatsoever during the lens disassembly with this technique. So this is the final quadrant. You can see I was little by little breaking up this lens into small quadrants. And this is the final quadrant here. And again, it's the same principle, grabbing with vacuum, but keeping the chopper deep, and then crushing the lens piece whenever the vacuum is not initiated during that step, and then just continue to repeat the same maneuvers. So again, it was a little bit cumbersome. It took some time, but you can see this is a very confident way, very safe way to disassemble a lens, especially in a Morgagnian cataract. So I take the chopper out, push BSS in, take the phaco tip out, and place the INA handpiece. I go ahead and start to do cortical removal with the INA handpiece underneath the rhexis. Of course, this is a Morgagnian cataract, so there might not be much cortex in the bag. You can see I actually grab the capsular bag on the right side there, again, suggesting that this is a weak zonule situation, which it is. And with these dense lenses, I'm always prepared to put a 3-piece lens in the bag. So I switch to the polish mode. I'm trying to remove some cortical wisps subincisionally, and then I place my cannula and pulsing the subincisional space to remove any potential lens material. Once I'm done, I'm injecting some cohesive viscoelastic to fill the capsular bag. And in this case, I decided not to do any polishing. Again, because this patient's not cooperative and have unpredictable movements, I decided to expedite the case. And so I'm widening my incision with my diamond blade to accommodate the three-piece lens. So the lens is being injected. The barrel is positioned facing to the left. The leading haptic will come out planar, parallel to the iris plane, pointing to the left. Place the leading haptic within the bag. As the optic is delivered, you want to rotate it counterclockwise 90 degrees so the optic comes out flat. Make sure the trailing haptic is pointed to the right. Use a Maltzman to push the optic-haptic junction and dial the trailing haptic into the bag. So I go underneath the lens, remove the viscoelastic from within the bag, remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who was very difficult to examine. He was very uncooperative in the clinic in the slit lamp. We were wondering if this was a sublux lens versus a Morgagnian situation. We did retrobulbar block as well as propofol drip, and we were able to determine he did have a Morgagnian cataract, but we were prepared for whichever situation we were going to get in. We used trypan blue to illuminate the capsule, used a systotome as well, got a nice centered incised rhexis in the process. Again, because of the free-floating nature of the lens, I think sculpting techniques would be very difficult because you need some type of scaffold or support the epinucleus and the cortex to hold the endonucleus in place as you sculpt. This lens was wobbling all over the place. Of course, you can lollipop the lens and stab it and do a traditional chop technique, but I don't like the idea of stabbing the lens with ultrasonic energy or vacuum. So I really use mechanical fracturing forces to position the lens between the chopper and the fingertip, crushing the lens piece. You did see I did prolapse the lens up out of the bag with the reverse Sinskey hook, but very carefully and systematically just crushing and sandwiching the lens between the chopper and the fingertip. And then again, when I'm ready to position the lens on my tip, you'll use a little bit of vacuum, but protecting the bag the entire time. But when I'm actually doing mechanical fracturing, I'm not using any vacuum, which is very safe to the posterior capsule. You can see here the patient's moving suddenly while I'm trying to hydrate the incisions. And so again, this was a really challenging situation. Thankfully, our staff did such a great job in controlling this eye as well as we could. And during the most important steps, he didn't really move, but you can see here at the end of the case, he started to move quite a bit here. Again, very unpredictable, potentially very dangerous, very risky. But thankfully, because of our techniques, because of anesthesia, the patient did very, very well without any complication. And again, I do feel mechanical fracturing techniques does provide an added layer of safety with these challenging cases. So I hope this was helpful to you, and I thank you for your attention.